Um, yeah, and just as a bit of a reminder that this will be recorded, and if everybody's okay with that, and it will be going onto the YouTube channel, as you can see on the front. Um, I'll quickly introduce Kieran today, and he is a clinical director of research at Streamliners and supports research and evaluation across the global HealthPathways Network. After training in medicine, Kieran developed an interest in health system improvement through working on a range of initiatives during the transformation of the Canterbury health system, including care pathway development, referral quality improvement, and patient flow optimization. And before I pass you on to Kieran, Tina, can you just change to the next slide? We're just acknowledgement of country. I acknowledge the traditional custodians of the Macquarie University land, the Watamagal clan of the Darug Nation, whose cultures and customs have nurtured and continue to nurture this land since the Dreamtime. We pay our respects to elders past, present, and future. And I'm in Darkinjung country today. So welcome. Sorry, Kate, did you have your hand up? Okay. Um, no further ado, we'll pass over to Kieran. So we'll close our slides down. And Kieran, if you'd like to start sharing your slides for your presentation. Thank you.
Thanks, Karen, and thanks for the introduction. I'll share my slides in just a moment. Hi, everyone, and I just wanted to say thanks to the group for having me present. I suspect I may be one of the least qualified people to present to this group. I'm not an implementation scientist, and in fact, if you'd asked me a year ago what implementation science was, I might have given you a blank look. So what I am, though, perhaps is an implementer, and I think there's a lot of opportunities and intersections between our worlds, and I know many of you will also be implementers. So hopefully this is an interesting discussion for you, and I'm looking forward to the interaction later on. So I'll see if I can share my slides. Is that good, Karen?
Yeah, all good. Thank you.
Cool. So for those of you who don't know about HealthPathways, it's a care pathways platform that's intended to improve the experience of both patients and clinicians, and also to help get evidence and policy into practice at scale. Now, I titled this presentation Health Pathways Scaling Success or Implementation Science Puzzle. And I don't know the answer to that question, actually. I'm looking forward to the discussion. I may have as many questions as you do at the end of this. Before we jump into it, here's a different kind of pathway. I like all kinds of pathways. This is the Hooker Valley in the South Island of New Zealand. I was born in the south of the South Island of New Zealand. My parents were both actually originally rural GPs. So from quite a young age, I kind of got this sense of both the importance of general practice, but also the challenges. So not only do GPs need to understand something about the hundreds of different conditions that might walk in their door at any given moment, but they've also got to work out how the local health system works and how to navigate it for their patient and how to get help when they need it. When I was about 5 years old, we moved from rural Southland to Christchurch City, and my parents didn't know anything about the local health system at that stage. So when they were trying to help their patients, they would need to ask their colleagues down the corridor, ring around the system. Sometimes it was just a case of trial and error to work out how to get help when they needed it. And my mum said it took her about 3 years before she felt really confident practicing in Christchurch. And so it was clear to me that the experience that patients would get did depend a lot on the experience and the knowledge of their doctors. This didn't deter me for some reason from also studying medicine, but really I found my passion in health system improvement. And that was largely by accident, because I was in Canterbury at a time around 2009 when there were some visionary leaders there who had set about trying to create a health system that was like this and centered around patients, where care was delivered at or near their own home, and hospital services were reserved for the people that really needed them. And I became part of a team called the Canterbury Initiative that was charged at working at the interface between primary and secondary care. And the way that team worked was to bring together a small number of GPs and specialists around a particular condition or presentation, and to talk about what was working and what wasn't working for them. Now, these GPs had sometimes been referring to the specialists for many years without having even ever met them in person. So from the start, it was about building relationships and trust between clinicians across the system. And at the end of those work group meetings, there would be a whiteboard that was full of ideas and opportunities. Mostly it was about what wasn't working. In amongst that, there were things that would depend on changes to the funding or the model of care, but much of it was really just about sharing information. So the specialist might say, well, if you included this information in your referral, then we'd be able to do a better job of prioritizing access to outpatient appointments. And the GPs might say, well, if you actually had a phone number that we could call to get some advice when we needed it, we might not need to make those referrals in the first place. It really became clear after a few of these work groups that we needed a place where we could write these things down so that everyone could access the information. People didn't have to work it out for themselves every time. And this led on to the development of community health pathways. And Community Health Pathways is a website that's designed for general practice teams, that's written by GPs for GPs, and it incorporates best practice evidence with information about how the local health system works. And each pathway is focused on a particular presentation or condition. It covers how do you assess people with that condition. It also covers what you can do in primary care to help manage their condition. And it also includes information about how to access support and referred services when you need them, both in the community and in the hospital. Subsequently, we developed a companion website called Hospital Health Pathways, and this is very similar, but the target audience here are junior doctors working in a hospital setting and senior doctors that are working outside their area of expertise. So these two websites together hopefully provide an integrated picture of the patient journey and mean that people get the right care at the right place and time. Mostly, hopefully, in the community, but where people do turn up at the emergency department, that those who could still be managed back in the community can return as quickly as possible, and that when people are admitted, there's agreement about which department they need to go to, and when they're admitted, the discharge planning starts on day one to get people back out to the community as soon as possible. Health pathways became essential really to how we did health system improvement in Canterbury, and other health systems came and started visiting and said, look, we'd actually like to do that too. And so over the last 15 or so years, what started in Canterbury has grown to cover most of New Zealand, Australia. There are a number of implementations in the UK and most recently in Canada. So more than 50 local health systems, collectively responsible for the care of over 30 million people. And you can see down the bottom there that in the last 12 months, there have been over 16 million page views. So hopefully each time that's leading to a better decision between the doctor and the patient. And that there have been thousands of GPs and specialists and nurses and allied health professionals that have contributed to pathways over time. In each of these local health systems, we help to set up a program team that's employed by the local health system that includes clinicians who work on localizing the pathways, and a team of administrators and planners that plan out a localization program and an engagement program with the local clinicians. And this is not, we call it the Health Pathways community, but it's not just a community, it's really a community of practice. So Canterbury had to start from scratch and do all 600 or 700 pathways without anything. But when a new member system joins the community now, they have access to all of the pathways that other health systems have done, so they're not starting from scratch. They can pick the pathways that are most locally relevant, and they only need to change the bits of those pathways that are different within their context. So we get some economies of scale by working very collaboratively. You might be curious about the organisation that I now work for called Streamliners, which sort of sits behind the Health Pathways community. Streamliners is a social enterprise, so it blends commercial discipline with a really strong sense of social purpose. The ownership is 80% with a charitable trust called the Just Trust, which stands for Joined Up Systems Trust. So the purpose of that trust is to support integrated care. And the other 20% is owned by Health New Zealand, the New Zealand health system, in recognition of Canterbury's initial contribution. So what's the evidence? Well, a lot of the research is focused on the clinician experience aspect of pathways. This survey is one of many, but was from South Tyneside in 2023 and shows that the majority of clinicians there are using it weekly or even daily. And on aggregate, most clinicians estimate it saves them around an hour per week. They'll also report that they believe it improves the quality and efficiency of care that they deliver to patients. But health systems invest in pathways because they want to improve the quality and efficiency of care overall. And I guess most of you will be familiar with the concept of the learning health system, and the basic idea being that as clinicians are delivering care to patients, we're generating routine data that if we inspect and analyze that data, we can learn things about what's working and not working. That generates new knowledge about how the care processes could be improved. And hopefully that then can influence practice and so on. So as a system, we can learn from doing and continually improve over time. And there are many frameworks and theories around learning health systems, as you're probably aware. In practice, it can be a bit more difficult than in theory. So one of the areas in particular, which I think is often a challenge, is getting the knowledge that you extract from the routine data back into practice. So there's often an implementation gap here. And why is that? Well, I think 20 odd years ago, Gabay and LeMay did a really interesting study, ethnographic study in a high-performing general practice in the UK. And they set about with this question of how do clinicians actually make decisions at the front line? Prior to this, I guess the idealized version of evidence-based medicine was that you do the primary studies, you write the clinical guidelines, and then practice adjusts accordingly. But what they found from observing from within a practice, the actual decision-making processes, was that it was very, very different from that. That in fact, clinicians would almost never refer to a clinical guideline in their day-to-day practice. The way that they made decisions depended on a whole series of different things going on inside their heads. And these were heuristics and rules of thumb that they'd developed over many years of practice. It was the social knowledge that they'd gathered from talking to their colleagues in the tea room. It was things that respected peers had said to them. It was industry influence. And then it was things about the local health system. What is the population of patients that they're seeing? What's the prevalence of diseases? What access do they have to local services? These things aren't covered in the guidelines. And most importantly, it was things about the patient in front of them that no guideline could cover, which is what are their goals and preferences? What's their social situation? What resources do they have at their fingertips to actually cope with this condition that they're facing? So it was a much more complex picture. And they dubbed all of these things mind lines. These were the things that were going on inside clinicians' heads. There was a social process, and that was how the actual decisions were being made. And you can see that whilst pathways don't necessarily capture all of this, they do go a step further than clinical guidelines, and a lot of that information that had to be learned socially can actually be written down alongside the best practice evidence in a way that helps get it into practice more quickly. So that's really the function of health pathways inside of a learning health system, is to help accelerate that knowledge into practice part of the learning cycle. And there are a growing range of publications describing models of care that have been put into practice using pathways. And of course, most of the pathways that are developed don't actually end up getting published. But many of the health systems using health pathways now see it as an integral part of their overall process of improving care over time. This interesting paper from the Australian Institute of Health Improvement, led by a GP called Bianca Forrester in Western Victoria, describes how Western Victoria and Australia have gone a step further and really created more of a formal primary care learning health system, drawing on a number of different things, including analysis of data, but also their application of health pathways. So if you're interested in going a bit more deep and you haven't read that paper already, I'd recommend it. So that's health pathways as an enabler of system improvement. Obviously, in the end, health systems really want to know, is it actually improving outcomes for patients, outcomes for the population? Is it helping us make the best use of our resources? And is it improving health equity? And this is where the research is much more challenging, because you've got a complex intervention, care pathways, inside of a complex system, which is health, and attributing things directly to the pathways is always going to be difficult. And to achieve these outcomes, you need more than just the pathways. You need the clinical leadership, you need the models of care, you need the funding changes, and so on. Additionally, because there are 600 or 700 pathways, no health system's actually been able to do a comprehensive evaluation of their health pathways program. But what they have done, when you look across the health pathways community, is a number of evaluations of specific pathways or suites of pathways. And in the current environment, it's become increasingly important that health systems are able to justify their investment in pathways. And so we had our first go last year at trying to do an economic analysis. What we did was we set up a model population of 5 million people, said if you implemented health pathways in this population over a 5-year period, and you took those different studies that have been done around the community on specific pathways, and you could achieve those same outcomes in this model system, what would be the costs and what would be the savings? And on that basis, our analysis suggested that you could potentially save $9.76 for every dollar that you invested in pathways. Now, this was a relatively naive approach on our part. We hadn't done a lot of economic analysis before. We did have the help of a health economist, but through that, we also learned that there were other methods and better methods, perhaps, for doing economic analysis of integrated care type interventions. And so we formed a partnership with the International Foundation for Integrated Care and with the University of Newcastle in Australia and their Australian branch to do a scoping review of the literature, to look at how had people done economic analysis of care pathways, what could we learn from that, and what could we share with the community to help do better over time. We're fortunate to attract a pretty high-powered group of advisors on the project with a mixture of qualitative, quantitative, and health economic experience. We presented the preliminary findings at the IFIC conference in Portugal just recently, and we're hoping to be able to publish those or submit them for publication at least in the next few months. I think there are lots of opportunities, though, to do more research and to draw on the expertise of the implementation science world. So what are some of those opportunities? In the first instance, I think there's a lot more that we could do to examine how different health pathways programs are going, how they could be improved over time, and to learn from each other. I think there's a lot of opportunity to look at variation. So that includes both pathway to practice variation. So are people following the pathways? If they are, why? If they are not, why not? What can we learn from that? and also pathway, what I call pathway to pathway variation. So if you look across different regions in New Zealand, Australia, the UK, Canada, what variation is there? How much of that is warranted? How much of that is unwarranted? And what can we learn from that? And then, of course, what we've just been talking about, outcome evaluation. So what impacts are pathways actually having? And we can look at that from qualitative, quantitative, and economic perspectives. What's become clearer to me, though, over the last 12 months as we've been focusing more on the evaluation side of pathways, is that most health systems don't have the expertise necessarily or the resources to do this well. So we'll come to that in a moment. Going back to the title, Scaling Success or Implementation Science Puzzle, in my unbiased opinion, this is one of the most interesting charts in implementation science. May not be realized yet, but each of these lines here on this chart represents one of the regions, one of the local health systems implementing health pathways. And along the bottom, you've got the number of years since their Health Pathways website went live. And up the vertical axis, you've got the number of page views in the last 90 days normalized to the population of that region. And this allows us to compare over time, to some degree, the performance of the programs as measured by our clinicians using the pathways. Are they referring to them regularly? And that red line you see at the top right there, that's Canterbury, in case you hadn't guessed it. And what's surprising about that line to me is that I would say probably just about every clinician in Canterbury has known about health pathways for the last 10 years or more, and yet it's still climbing over time. You can also see that there are a number of others climbing along a similar trajectory, and you can see that there are many that aren't. They're on a much lower gradient. So for me, there's something really interesting in here in terms of what are those differences, both in terms of the environment that the implementation's happening in and how those specific programs are running that mean that these trajectories are so different. What can we learn from that as a community? And then can we help those that are on those lower trajectories to improve the gradient and catch up with some of the other ones? Going back to the challenge of actually doing these evaluations well, what I've also become more aware of is just how much capability there is actually out there when we look at organisations like the Australian Institute for Health Innovation and many others in Australia, New Zealand, UK and Canada. And also that these academic groups do have access to grant funding that health systems themselves don't necessarily have access to. So focus for us now is to actually see if we can bring these different worlds together, because I think there's a lot of opportunity for collaboration. I think there's a lot of common interests, and conversations like these are a step in that direction from my perspective. So I hope that that was of some interest, and I look forward to the discussion.
Thank you very much, Kieran. That was very interesting, and a great overview of where we're at to now. And I think, you know, like you summarising it at the end. So there's a bit of work to do, and it'd be great to sort of have more collaboration around this space, I think. Is there anybody got any questions to start the chat? I can't see all the hands at the moment. So if there's anybody, is it because there's nothing in the chat? So let me know if anybody has got a question. I've got a question, so I can start first of all. Oh, here we go. Margaret Ryan has put in, does Health Pathways incorporate allied health, speech pathology and audiology more specifically?
Thanks, Margaret. There's a few answers to that. So the first answer is that all clinicians contributing to the care of patients in the health system have access to community and hospital health pathways. And that in itself can be quite useful, because although the target audience for community health pathways is general practice, often there is a lot of useful information in the pathways for allied health professionals as well. And the second part is that there is actually another version of Health Pathways, which has only been developed in Canterbury at this stage, called Allied Health Pathways, and that's targeted at allied health clinicians and does indeed cover some of the things that only they're seeing, or from a perspective in which they're seeing certain conditions and presentations.
Does that answer your question, Margaret? Yeah. I noticed Yvonne's got a question. Do you want to ask the question,
Yeah,
Yvonne? Or,
sure.
yeah.
Sure. So, Kieran, I was fascinated by that graph you showed, which you said you were as well. I'm just wondering whether you've got any insights as to why some regions are so prolific in taking up and continuing to increase the use of pathways, whereas others are not. What are the characteristics of those, the high uptake regions compared to those that don't seem to be uptaking it as much?
Well, yes, thanks, Yvonne. And we know something about that, but probably there's still a lot more to learn, as I alluded. So, firstly, there are some occasions where we know that a program is really struggling, like it might have lost its sponsorship, or its funding might have been cut, or key clinical leads might have disappeared. And so the continuous improvement aspect of it falls off, and so we can often see the line was going on one trajectory, and when those, whatever those changes are, happen, we can see that it either flatlines or sometimes even goes in the other direction. So there's a few of those. I think the majority is to do with environmental stuff. So Australia, relative to New Zealand, UK, Canada still remains to be seen, seems to be a more challenging environment to implement in. So many of the Australian implementations, even if they've done all the right things, at least as we understand it from a program perspective, the user engagement will tend to be lower than in New Zealand or the UK. So I think understanding why that is probably some, still an area for more research. We've got some theories, but I'm not going to bias the research by putting them out there just at the moment.
Thanks.
Thank you. And so, Karen, you've got a question as well, Karen McLaughlin. Do you want to ask the question?
Yes, I do.
Yeah.
Basically, yeah, hi. So I'm a clinician, and I'm trying to get a new resource. So I'm interested in asthma and pregnancy, and I'm trying to get the asthma and pregnancy toolkit, which is a new resource, added to all of the health pathways in New South Wales. And I'm finding that a very tricky thing to do, in that there's no one central person. So I'm just checking. I need to go into every local health district and find the person responsible. Is that correct?
Yeah, good question. And perhaps I'll take a step back and then come to the specific question. So when we started Health Pathways, it was always a bottom-up thing. It was implemented from a local level. Now, over time, as more and more systems came on board, there was increasing interest from government or state level, because they could see the potential to help get evidence and policy into practice at scale. So, for example, although the 20 district health boards in New Zealand originally implemented it all themselves independently, there's now a single national health pathways program in New Zealand. It doesn't mean that they don't still have localized versions. They do, but it's a more coordinated effort. Wales in the UK was the first country to do a whole of country implementation across their 7 health boards from the start. So that was a step in the right direction. And in Wales, they actually collaborate on all of their pathways. In the last 12 months, they've managed to go from 0 to 200 nationally agreed pathways. And when you're working in that way, it means you can do something like what you're talking about systematically. Australia, we're not there yet. Queensland, they do have a state level program, and so the collaboration is significantly more systematic. New South Wales, we haven't managed to achieve that yet. So we have been in discussion on and off with New South Wales Health, with ACI. We're really keen to work out how to get a coordinated New South Wales program, but at the moment it's not that. And so I think you've got 12 or so independent implementations, and it is as you described. Now, we do and have established a sort of informal sharing group that meets on a regular basis between the Australian implementations, and if you want to contact me offline, we can probably help facilitate the process. But to really get to a slick mechanism, we will need some support and engagement at a state level to have those teams working more effectively together.
Great, thanks so much.
Thank you. Yeah, that's very interesting, because I think that coordination sounds as though that's a really useful process, isn't it? And it does seem to sort of speed the process up. Samantha, you've asked a question. Would you like to ask your question?
Sure. Thanks, Karen. Thanks, Kieran. I really enjoyed your presentation. Apologies if you already mentioned this in the first 10 minutes. I was late to the webinar, but I was just wondering if you could talk about how the clinic, how evidence-based guidelines or kind of that evidence is incorporated into the health pathways. I've seen some of the health pathways, and they're fantastically they seem to be evidence-based. They're very relevant, and I'm just really interested in how you bring those together.
Yeah, thanks, Samantha. I touched on it, but I think we could go into it in a little bit more detail. So the way it works is that every pathway is developed as a collaboration between, if we're talking about community health pathways, GP clinical editors, so that's practicing GPs who understand the needs of the target audience, collaborating with subject matter experts, and that's usually specialists and allied health experts and others who know specifically about the best practice for that given condition, working closely together. They will normally take a pathway that another region has developed and signed off in the past and work through what's different around here relative to that. Now, pathways are not heavily referenced, perhaps like a resource like UpToDate, but we do ask people to reference points that might be controversial or different in a particular environment because they have different patient population and so on. So it's kind of like a social process. The other thing that is different from a clinical guideline, which might be developed and then reviewed 3 years later, is that pathways are living documents. So every page on Health Pathways has a feedback button, and anyone in the whole system can click on that button and highlight something that they think might be wrong or out of date or isn't working because the services have been reconfigured. And so pathways can be updated overnight if someone identifies that something is now out of keeping with best practice.
Great, thank you. And yes, I do have experience of that with the living COVID guidelines and the health pathways also being updated. Cool.
Thank you very much. Is there anybody else online that's got a question or in the room? I had a question. I was just wondering, how do the clinicians learn about this, how to use this? Because that's also part of implementation. If people don't, if they just think it's too hard and it's new, then you often get barriers to changing practice. So I just wondered what the support what the support and the education and the learning, opportunities are.
Yeah, so we've learned something about that over the last 15 years. And in terms of the support we provide to local program teams, we have a range of strategies that we encourage them to implement. And there are many. Some of the most useful ones are tying pathways into clinical education. So in New Zealand, for example, we help run national webinars where the experts who have been involved in developing the pathway will actually then present on the key points of practice. And rather than people having to take notes or anything, they can just know that when they go back to their practice the next day, that information is also there on Health Pathways. So, and those are very well attended. Clinicians seem to like that kind of really practically orientated clinical education. Another area that's really useful is to make sure that the clinicians that are triaging referrals into hospital services are also referring to pathways. And if referrals haven't demonstrated that the person sending it has done the things that they could do in the community, then to point people back to the pathway where they can actually take a few more steps in the community before the person's seen in the hospital. I think going back to the question about what are the factors that influence the success of clinician engagement over time, awareness is definitely a factor, and it's a factor in Australia. And again, we don't quite understand why that is, but for some reason, clinicians in Australia, despite many of the program teams doing really good work around this, don't seem to be as aware. And it might be that there's just more different resources at their fingertips. It might be that perhaps the relationships between the organisations implementing pathways and the clinicians are not so strong. We don't really fully understand that. So I think that's an interesting area for further research.
Yes, I think that's yeah. I think Yvonne's got her hand up. There she goes.
Yeah, I just wanted to add, I've got a little bit of insight as to what's happening in Australia, and the things that we're hearing from PHNs, primary health networks, and from GPs themselves is that it's actually the pathways sit on a separate website. They're not embedded within their GP software, and that makes it quite difficult. So we're actually doing a study to see if we can embed a particular pathway and test it out into the GP software. And the other thing is each PHN seems to be developing their own. So for example, Western Sydney had pediatric pathways for many, many years, including a type 1 diabetes pathway, but Nippy and Blue Mountains only just developed their own type 1 diabetes pathway for children. So it's that sharing and having a national approach, I think, is really helpful, as you said, Kieran, before.
And I think that is a difference. Another difference between Australia, New Zealand, and the UK is the sort of federal, state, and local level. There's those three tiers, and we talked about state collaboration, but I completely agree. There's also opportunity for national level collaboration, and we are also in discussion with the federal government about those opportunities. So, because I think the ultimate would be that we have collaboration at national, state, and local levels, and I think that would help with reducing duplication of effort.
And I don't see any other questions, so I might jump in again. I was very interested when you were saying that how the GPs and specialists were working together and providing information on referrals, what to include in referrals to improve that, referral practices. Because I did a study in epilepsy, and that was one big thing that came through, and people were not referred to specialists because of the poor GP referrals. And I thought that was a really interesting one. And how do you build up those relationships? As you said, some people had never actually met people in person, and there is still, that clinical etiquette, or like you're the specialist and I'm the GP. How that's another part of implementing change, is actually building those relationships. I just wondered how you go about bringing people together.
Yeah, I think you've hit on a really important dimension of this, and it's perhaps a dimension that's often underestimated. So people focus on the website and on the end product, but actually Health Pathways is about the social process that leads to the end product. The end product represents the agreement, but it's really the social process that adds value. And that is an area that is probably done variably across the Health Pathways community. It does take time and effort to bring people together to have those discussions. It's not necessary for every pathway, but if you do it for a subset of the pathways, then you do find that even if people weren't in the room, that they might have a friend or a colleague who was in the room. So the trust kind of propagates through the system over time. And it is something that you've got to, it's a long-term game. So you've got to kind of commit to continuing to work on that over time. And it pays off in the long run.
And with that, leading on to that, you mentioned Hunter New England, the hospital and the community pathways. Are there many of those combined pathways? Or, that they've got both in the same area?
Yeah, I think we're up to about 5 or 6 implementations globally of community and hospital health pathways. There's 2 in New Zealand, 1 in Australia, and a few in the UK. So I think there's still a lot of opportunity there, and the 2 together are significantly more impactful than just the 1, because then you have the full patient journey agreed, and you can get some of the benefits that come from early discharge planning.
Yeah. And so what do you think is probably out of that list that you had at the end? What do you think is the key thing? Do you think it's cost is going to be the impacting factor, the cost effectiveness of this? What is it, do you think, that really needs to be demonstrated or, highlighted that people will then take, more of this on board?
Yeah, I mean, I think in the current environment, and things were very different pre-COVID, but in the current environment, cost has been obviously become a factor for everything, and it's being scrutinized across the board, quite rightly. So that's made things more difficult, and it's probably put more of an onus onto demonstrating value. So we're trying to sort of come at this to support the community from a couple of directions. One is we're looking at our systems and processes in the background to see how can we over time drive costs down, and things like doing more pathway sharing are really essential to driving the costs of implementing down over time and getting efficiencies of scale. And then we're also looking at it from the perspective, and I think this is equally or probably more important, how do you actually demonstrate value in a way that people can see that system investment actually pays off many times when you look at the savings and quality improvement opportunities from doing pathways. And that's certainly challenging work, and that's where I do think we need academia and health systems coming closer together and working in partnership and drawing on the expertise of people like those in this group.
Yeah. And I think I was just wondering about have you, do the patients, the people that are, the recipients of the care pathways, have they been, has there been anybody sort of spoken to them? Because I'm sure there are some people that have been through the health system a lot, and maybe noticed some changes in the way that, the GP is, managing their care, or they're, getting to services quicker. I just wondered if there's been any, engagement with them.
Yeah, that's a really important question too. So I think there are sort of two different approaches to localizing a pathway. And the first one is where you really do look at it from a holistic perspective. You run work groups, you think about what's the model of care. And when you're doing that, ideally, you're bringing in patients to that discussion. What is the model of care that would actually work best for you, for others with the same condition? Realistically, you can't necessarily do that for every pathway all at once. A program of health pathways would normally look to localize about 600 to 700 pathways over a 3 to 4 year period. And you can't kind of take it to that level for every pathway. The second type of localization approach you can take is just to say, look, what do we understand of the care process currently? What is current best practice based on what the clinicians and others contributing into that care know now, so that they don't have to walk down the hallway and talk to their colleagues or ring around or trial and error, because even if we can just get that really clear, we're going to save a bunch of time and we're hopefully going to get more quality and consistency of care. So you need to bring both of those approaches into your program and decide how much can we focus on adjusting models of care, how much do we focus on just defining care as it currently is so that everyone understands that, and then over time, how can we bring more and more patient perspective in to improve those pathways, because it's a living process and you're always looking for opportunities to make it better.
Yeah. I think Yvonne's got her hand up. I saw her.
Sorry. On your discussion there about involving the patient, and a lot of the pathways do have accompanying patient information and resources that patients could use. But certainly several years ago, when I was looking at a particular pathway, it was up to the GP to print that off for the patient. Why are we keeping this information behind, paywall, not paywalls, but behind passwords, when patients could actually be benefiting from these resources without needing to go and see a GP?
Yeah, that's a good point, Yvonne. So the pathways at the bottom of every pathway is a patient information section, and the intention of that is to make sure that the clinician understands what patient resources are available that are aligned with the broader care process outlined in the pathway, and what it links. But those patient resources are not developed as part of the health pathways process. They're usually links or references to other things. And in Australia, that might be resources developed by Health Direct or by the local health system. So I think the maturing of how can patients most effectively access patient information is a really important parallel question. And however that is, the pathways need to just refer to or link to those resources and make sure that the clinician can point the patient to them in the most effective way.
Oh, that's interesting, because I know there's, when you speak to patients, a lot of them feel that they don't, who is giving them the information. So like how that information is shared is always a big issue, because they can see multiple, clinicians, and they all think that they're getting the information from someone else, and then it's sort of, and I've just interviewed some people with motor neuron disease, and they all talked about the GP being the gatekeeper, and that was quite or the manager of their care, and so like that sort of highlights quite an important role that they have in sort of helping to sort of get them to where they need to be. So yeah, that's an interesting
Karen,
one.
were they using gatekeeper in a sort of positive sense or a negative sense, or was it neutral? I'm curious.
So some of them had really good relationships, yes, with their GP. Some of them were a bit challenged because the GP didn't actually know where to send them, and they spent a lot of time delayed diagnosis. Now, and with motor neuron disease, that's not a good process, because we often, they don't often have a lot of time. So I think there was a bit of a mixed bag with that. I think it just depended on their experiences, but definitely, and that's just a recent story about not getting to the right person. So it highlights for some people those rare conditions that where pathways could actually maybe speed up the process of getting to the right clinician. I think there's a question. Yeah, sorry.
I was just going to say that's certainly the intention. It does come down to, are people aware of the pathways, as we were discussing earlier?
Yes. Yeah. And Margaret, you've got another question here. Do you want to ask that question?
Sure. I was just wondering how you deal with issues of privacy. Obviously, you need the health professionals to know the relevant details about the person, but it's always an issue when people are talking about someone without them being present or without their consent. Is there anything that you can do to try to retain the patient's right to decide which information gets sent to who?
Yeah, so just to clarify, the pathways system itself doesn't interact with or hold any patient information. So the guidance provided is general purpose guidance, and the clinician interprets it in the context of the patient in front of them. In terms of sharing information outside of the consultation, I guess there is opportunity with Pathways to ensure that only the necessary information is shared in referrals, and potentially to highlight the importance with some conditions, and some pathways do this, about discussing that with the patient and making sure that they're comfortable with whatever might need to be shared.
Thank you.
Thank you. Yeah, no, I do understand it's a system of procedures, not of specific information. But just a couple of the things you said just raised that question in my mind, that where it's lovely to have health professionals from different areas talking to each other, but that is an issue that always needs to be considered, I think.
Yes, and in those work group discussions that I mentioned that might be part of the process of developing the pathways, there wouldn't normally be any specific patient cases discussed. There might be examples of, anonymized examples of where things didn't quite work right, but they wouldn't normally discuss a specific patient case.
And I suppose, sorry.
No, sorry.
It's just going to. I suppose there would be situations where you could speak about a case, but not, you wouldn't need to use that person's, identify as their name or identifying details, just as we might do in research.
Yeah.
And I was just going to ask another question. Sorry, just one more bit. Do you find that these pathways have helped GPs with their engagement with specialists, that's improved?
Yeah, so that is something that's been studied in a number of surveys, and both GPs and specialists report, the majority report that they feel that it's improved their relationships. So that's, I think, one of the important side effects of actually going through the implementation process together. Yeah.
That's great. And so we both sort of get a bit of an understanding of each other's perspectives of, working in that environment. Yeah. All right. That's wonderful. Is there anybody else got any questions there? Because I haven't got everybody. Well, it's 1:25. So I'd like to thank Kieran for coming and joining us, and having a wonderful presentation and a really interesting discussion today. Really great. And we look forward to sort of working maybe more together, and sort of working and sort of helping to sort of develop it, maybe a bit less siloed working in Australia and a bit more engagement. And that would be great. Thank you very much. We really appreciate you coming. Thank
you, Karen, and thanks everyone for the great questions. And don't hesitate to reach out. I think you've got my contact details in the slide deck, so if you're interested in anything, I'm very happy to correspond. Yeah, thank you very much, Kieran. And just for anybody, just to remember that there will be this presentation on the YouTube channel for anybody that'd like to revisit it or share that with any other colleagues. So thank you very much, and we'll look forward to seeing everybody next month. Thank you, Kieran.
Yeah.
Thank you, everyone. Bye. Bye.